Good evening, everyone. A very warm welcome to all of you for the wonderful evening and our meet together. Myself, Dr. Nishant Shigaokar from Akash Eye Clinic. I'm a consultant over here and been practicing ophthalmology since 8 years. I'm here to introduce you to all the panelists and the speakers for today's event. Our first panelist is Dr. Professor Ramesh Mehta Sir. He's a member of the Royal College of Pediatrics and Child Health Council, founder president of the British Association of Physicians of Indian Origin, UK, and a fellow of the Higher Education Academy, UK. He's also Secretary General for the Global Association of Physicians of Indian Origin. Welcome, Dr. Professor Ramesh Mehta Sir. Our next panelist is Dr. Professor Dediya Sir. He's a professor of ophthalmology at Maulana Azad Medical College and director at Guru Nanak Eye Care Center, Delhi. He's a president of Delhi Ophthalmic Society and an ex-president of the Strabismology and Pediatric Ophthalmological Society of India. He's an active member of All India Ophthalmic Society, has written CME series on amblyopia in various credits, and has been credited over 100 publications and has been invited as a guest speaker at various national and international conferences. These are the panelists as on international, on Star Wars level. The next panelist for today's event is Dr. Pk Pandey Sir. He's the Secretary of Strabismology and Pediatric Ophthalmological Society, Delhi. The next panelist is Dr. Jignesh Taswala Sir. He's a dynamic person and a medical director and proprietor of Darshan Eye Care Center, Pune, a senior ophthalmologist doing practice since 24 years, and honorable president of the Maharashtra Ophthalmic Society. He's honorable past president of the Pune Ophthalmic Society as well, and a section editor at International Journal of Ophthalmology. Welcome, sir. The speakers for today's event are two, Dr. Nitant Shah Sir and Dr. Pradeep Deshpande Sir. I would like to introduce Dr. Nitant Shah Sir. He's a gold medalist person in all aspects, right from the MBBS and from the DNB period. He has done his super specialty training at vitreous and retina at Shankar Nethralaya, Chennai, and also did the FNP retina and also specializes in vitreoretinal surgeries, lasers, posterior segment trauma, and has performed over more than 5,000 vitreoretinal surgeries and over 10,000 lasers. We are very obliged and humbled to have you, sir, over here for today's event. The next speaker is Dr. Pradeep Deshpande Sir. Age is just a number for him. He's a recipient of Distinguished Scientist Award. He's a president-elect at Strabismology and Pediatric Ophthalmological Society of India 2021-22, and has published a unique research paper for the management of the meridional amblyopia by Access Video Games. Presently, he is a consultant squint pediatric ophthalmology specialist and amblyopia specialist at Vimannagar Laser and LASIK Center. Welcome, Deshpande Sir. I would call upon Dr. Pradeep Deshpande Sir to take over and present the first topic.
Welcome. Share the screen. We'll do that. Good morning, my brothers and sisters, and all the young people, children specialists, as well as all the postgraduates and doctors. Why I say good morning? Because I can see your faces. They are absolutely bright and smiling. So always I say good morning for those people, those who are really smiling. Keep this smiling till the end of our lectures. And if you don't smile, I will say good night. I'm very happy to share my experience, my research of last 50 years only with you. It's a diamond jubilee year of my life where I'm going to, during my all, I can say, mandatory hours, I would like to hand over all the runs which I have collected during my 75 years or 50 years of my practice to all of you. I'll be happy if you get something from out of that. I would like to share everything with you. I'm very happy to share with the pediatricians also. They have already come here by their they have come here and they are going to listen on the. I'm going to share specific topic for them. What are the alert symptoms and signs where there is all these frontline pediatricians will be able to help, will be able to prevent the blindness. Most of the practical tips and the foundation are the foundation stones laid down by the legends in ophthalmology, as well as simple practicable solutions from my practice and research of just 50 years. Almost 85, just remember, almost 85% of the knowledge is gathered through the eyes, and our eyes consume more than 65% of brain energy. Dear respected friends, kindly spend some time to look for the following important things along with your Apgar score. Most of the pediatrician, they are called to see the child at birth. This is a routine practice. And they calculate a Apgar score, if I am not wrong. Similarly, at the same time at the birth or before first month of life, we should see these important things. Number one, the development of the eye, both the eyes, development of the cornea, then fixation reflex, pupillary reflexes, and there is one Bruckner's red reflex. As in many general practitioners, as well as pediatricians, they are using a direct ophthalmoscope just to see the Bruckner's red reflex. That will give you so many clues in the very early stage. Then the blink reflex is something new, not in books probably. Blink reflex, we just put the light over the head of the child of that particular room, and the child will immediately blink if the child has vision. It's a simple thing to see whether the child has vision or not. Then watering or secretions. Any watering before 3 weeks after birth is abnormal, unless the child is crying. Another important milestone that all the pediatrician must know, they must see at the age of 2 to 3 months, there is a development of binocular vision. Binocular reflexes will develop at that time. And eye coordination develops. Before 3 months, usually one eye is going here, other is going there, like that. But after 3 months, when the binocular reflexes develop properly, there is a good coordination between both the eyes, and you don't see any squint. But if there is a squint after 3 months or 4 months, it's an alarming sign. Immediately, you have to refer the child to that squint may be because of real muscle problem, developmental problem. It may be because of low vision due to amblyopia, or rarely due to retinoblastoma. If the retinoblastoma is affecting the macular area of that particular child, then that particular eye will go on deviating here and there. And there will be a squinting tendency. So you have to refer immediately. Oh, there is something very serious now. We have to refer it to the particular retina person. What is the earliest time to assess the vision? Can you assess the vision at 2 to 3 months of life of a baby? It's very difficult. But I have developed particular simple practical methods. You can see here. This particular drum, the strips will move. This is known as Oliver, Catford or Oliver drum. When it will start moving, then you can elicit a optocorneal nystagmus over that the child. You can appreciate the feelings of the child or face of the child, that there is something there. Then you can see that whether there is a vision or not. Or just put a doll over the cradle of the child or the roof of the room and let it come down gradually. If the child starts seeing, immediately you will look here and there and you'll find the difference. These are the simple tricks. You can teach these to your parents. Here are the same thing that you are bringing the child towards that particular strips, and you can measure the distance from the eyes of the child up to the strips. And that is the vision of the child at the age of 2 or 3 months. Well, at the age of 2 to 3 years, when the child learns A for apple and E for elephant, at that time, this is the best time to screen amblyopic or lazy eyes babies. When the child is brought to you in your clinic, the parents will tell the child that we are taking you to a hospital. Immediately the child will start crying. But when the child comes to you, if you show them some pictorial charts, animated objects like E for elephant, A for apple of the same size of that 660 letter or 636 letter, then you can easily assess the visual acuity, and this will be up to the age of 5, it will be almost 612. Well, the child is unable to tell you, he is crying. But in our institute, Akasha Institute, we have a very good, wonderful equipment in our hospital. That is known as Opal Scan. Just put the child head there and you will get assess everything. There are so many things that you can assess. Doctor will tell you what are the different things that you can assess, whether that he has a particular number, he has any keratoconus, he has any other problems, all the things, whether that refraction is because of the lens, cornea, all the things will be assessed by the equipment immediately. Very simple and beautiful equipment that we are using regularly. The visual acuity usually develops, 6 vision develops at the age of 4 to 5. Before that, it will be little less, 1 or 2 lines less. Then coming back to the important topics where you have to remain alert all the time. These are conjunctivitis, foreign body, corneal involvement, congenital dacrocystitis, congenital glaucoma, congenital cataracts, retinoblastoma, high refractive errors, amblyopia, strabismus, stimulus deprivation, lesions, and ROP. About these 3-4 things regarding the retinoblastoma, regarding the ROP, our doctor, well-known person, he will tell you all about ROP. Now I would like to elaborate about the common things. The commonest thing is lacrimation or secretions, watering of the eye. The lacrimal gland starts secreting after 3 weeks, during 3rd week to 4th week of life. Any type of watering up to 3 weeks is taken as an abnormal thing. Either it is because of conjunctivitis, usually bilateral, with a different type of discharges, maybe a purulent membranous, hemorrhagic, watery or mucoid, and accordingly you have to treat. But in all the cases of conjunctivitis, where there are purulent, membranous or hemorrhagic or these gonococcal infection, ophthalmia neonatum or bacillus pyogenes infection, all the pediatricians should hammer all the time. You are the best counselors and you are perfect family physicians for the particular family. So they will listen to you. Only you have to hammer them all the time and tell them to pour broad spectrum antibiotic drops every 2 hourly, clean the discharge by a sterile cotton. Take a sterile cotton, put 2-3 drops of any antibiotic and clean the leads. Instead of just boiling all the cotton and doing simple tricks for any, after cataract surgery or anywhere, take the sterile cotton, soak it with the antibiotic drops and use it to clean the leads and keep the eyes open. Let me tell you, I have seen so many children where the children were brought to me very late, and by that time the child was continuously crying, and I could immediately, that struck to my mind that there must be corneal involvement. The particular bacteria or any particular things like bacillus pyogenes of gonococci, they can invade even the normal cornea. And within few hours, after closing the eyes for few hours, the child is brought with a corneal ulcer, then perforation, and lastly, there is complete blindness of that child. Usually they say, all the parents, they come to us, they say, Sahib, डोळे बंद राहिले काही दिवस आणि डोळे गेले, डोळे आले आणि डोळे गेले. They say like that. So in all these cases where the child is closing the eyes, if the child is crying continuously, the crying means there is something involved, that cornea is involved. Because cornea is a highly sensitive structure of the body. So please, in all these cases, don't allow the eyes to close, keep it open. Then very rare condition, but you can diagnose if the children specialists, if they can refer in time, then I will tell Rashtrapati to give you an award. Because only you people can diagnose at the earliest stage. What is the earliest stage? Let me tell you about the bilateral watering. Below 3 weeks after birth, it is a abnormal, that I already told you. And in these cases, there is no congestion, there is no redness, only there is a watering. And one important thing that you should not miss, if there is a severe blepharospasm or photophobia, fear for light, if you just put even a dim torch light, the child will immediately close the eyes and start crying. No redness, no inflammation, nothing. Only watering and blepharospasm or photophobia is a hallmark of congenital glaucoma. Refer the child immediately. If you have an ophthalmoscope, you can see, here you can see that Yes. In left eye, the cornea is little larger and there is opacity in the central area. And even if you diagnose at this age, we can save the other eye also. And we can save the further damage of the cornea. But in late stages, you cannot do anything. When the cornea becomes totally white, the size of the cornea increases, the optic nerve damages, and the child remains blind all the life. But you can diagnose early changes just by looking at the photophobia. No congestion, nothing. And if you refer those cases to a particular cornea specialist or a glaucoma person, then you will be rewarded with a Rashtrapati Award. Okay? It's a very important thing, though the incidence is very less, but at your level you can try. To remove the foreign body, you can hold the child like this, but again, the child will never come to your hospital again. And one more important thing is the commonest thing that you are coming across, that is the nasolacrimal duct obstruction or congenital dacryocystitis. Commonly, I have seen everybody tells, oh, to the parents, go on doing the massage of that particular area, the sac and the nasal bone, at least 3, 4, 5, 6 times. And I have seen that I have seen laceration over that particular skin. There is a bone below that particular area. Why you are doing massage? Remove that word massage now. Don't do any massage. Your aim is to create a pressure over the sac so that the fluid will go down and the cell debris or the fine septa present there will be dislodged. What is your aim? Just to dislodge these things by creating a pressure over the sac. So best way is to pump the sac 7-8 times. Just put a finger. What I do, how I tell, yes, keep your finger like this. Tang, 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 tang. Just a friendly way. You can teach the parents like that. So the child will not cry. Or the child will get frustrated like anything. There will be laceration. So just do a pressure over the sac. Remove the fluid inside. Clean it properly. And then put the antibiotic 2-3 drops. These drops will be sucked inside the sac. And then again do the same procedure. Pump it again 7-8 times. So it will create a pressure on the nasolacrimal duct. In all these cases, go back. Let me continue without my slides also. Most of the children, they are brought to you by with different types of foreign body. The foreign body of
So the main laptop has been disconnected, sir. Can you please confirm? Author, sir, can you please intervene and please confirm?
cases, when they come to us, usually we prescribe steroids. A short-term steroids or weak steroid, you can use it, but you have to treat the basic cause. The allergy may be intrinsic or extrinsic. For these extrinsic allergies, these anti-allergic drugs are enough. For intrinsic allergy, you have to treat. First thing is that you have to take care of the helminthiasis and different types of infections like giardiasis and any other things. Then the commonest thing that you come across, that is the congenital cataracts. Either it is present at birth, a wide pupillary reflex may develop just after birth or early in infancy. The opacities obstruct the visual pathway during the critical period of visual development. Let me explain you about the critical period. The visual developments, 90% of the visual development start during the first 2 years of life only. 90% vision develops. And during that period, if any opacity, maybe a small central, the lenticular opacity, or even 3 millimeter, more than 3 millimeter opacity of a cornea, or congenital cataract, a unilateral congenital cataract, these are going to result in severe type of amblyopia. And even after proper surgery, the vision will not improve. So the critical period is up to only 2 years. Then there is a sensitive period up to 7 to 12 years. That I will explain to you afterwards. I would like to tell you something for the congenital cataracts. Number one, we have to operate these cases before 8 weeks of age for getting a better visual outcome. If you operate late, it's very difficult to get the vision, total vision back. And these children, they usually present with a dense amblyopia or severe amblyopia, and very difficult to improve. Another important observation is that we have to operate both the eyes with a difference of maximum 1 week. If you operate the other eye after 1 week or after a few days or after a few months, again the chances of amblyopia are very high. And the secondary IOL implantation time, best time is after 2 years, not before 2 years, as per most of the. And I have already told you about the congenital monocular corneal opacity of then the ptosis, uniocular ptosis, or these corneal opacities. If the opacity develops during the critical period or the sensitive period, then even after performing the keratoplasty, the chances of getting the vision back are very less. If it is after that particular period, yes, good chances. Last document. Wait, don't do anything. Cannot go ahead. Well, that's all. I already told you everything. And the last but not the least, this is the era of all online education. All the children are depending on laptops. In those children, or if you are going to send a child for a nursery or KG also, please examine them thoroughly by a cyclopedic refraction and then repeat it after every 6 months so that the child will be able to study properly. There won't be any astronomic symptoms or any headache or dryness or anything. But it is mandatory to perform the eye checkups every 6 months, because as the child is growing, the number will also grow. If in myopic children, if the number increases very fast, so many companies like Intot, they have come out with a atropine eye drops, 0.01%, very diluted. You can put this drop daily at bedtime for the child, and this will arrest the progressive myopia. There are two things we have to observe in that child. One is the progressive myopia by the atropine, and another thing that you have to subject that child for outdoor activities at least 1/3 time of a day. These two things will help you in that case. I have seen many children, they are coming to us with, when they start the slow reading, writing, speed, and they are making so many mistakes. If they read a T letter, what they will read I. They will not be able to read the top of the T because the child has a cylindrical number, high cylindrical number. Or if you write 7 plus 1, they will say 1. 7 plus 1 is 2. You will not be able to read that top line if there is a amblyopic line or the neurons are lazy in that particular meridian. Is known as meridianal amblyopia. Well, this is all about the different things which I have told you. In the as a pediatrician also, I have seen so many pediatricians, they are developing their own techniques. They are for treating the children, and intelligence, experience, and capabilities are not enough. There will be a joy of doing something beyond, something beautiful. This was told by Dr. Venkataswamy. But I have read one more thing. Beyond imagination, you can play the billiards with the Polaris also. This is the research now. You can do that. And I have written one book on amblyopia, lazy eyes, innovations, practical tips, innovation, vision games, that is available on Amazon and Flipkart. The vision games on Play Store, and a tab where I can assess the vision at home, anywhere in the school, college, or in your clinic also you can assess. That is a Pradeep tab that was inaugurated by a president of American Academy to assess the vision, and on the same tab you get the games also. These games will run as per the axis of astigmatism for meridianal amblyopia children. Thank you very much for your patient hearing. Thank you.
Very nice talk, Dr. Pradeep Deshpande, sir. That was really illuminating for each of the pediatricians who have been here today to listen to your talk. Very practical tips that you have given, point by point, everything has been covered. Though we had some technical issues, it's the first time we're doing a hybrid meeting in Pune. So anyway, it was very nice. During the panelist discussion, we'll have all your questions answered. In the meantime, we'll take this second speaker, that another of our in-house consultant, Dr. Nitan Shah. He is going to address on retinopathy of premature vision. Nitan, please.
Thank you, Dr. Sarla sir, Dr. Deshpande sir, my friend Dr. Vittal, and all those who are gathered here. I'll be speaking today on ROP. So mostly I'll be covering a few basics for general ophthalmologists and for pediatricians, and certain recent updates or changes in the classification, as well as touch upon some new modalities of treatment.
Any questions you have, please write on a sheet and give it to me. So I'll start asking the panelists. We have the international panelists with us. So after listening to Sir's PPT and a lecture, everybody must be having some questions in your mind. Just make a note of it and write it down.
So we start with leukocorya, or the white pupillary reflex. This can be picked up either by a general ophthalmologist or by a pediatrician. And it can have multiple causes, right? From congenital cataract to the retinoblastoma, which is quite rare. Retinopathy of prematurity, especially when it goes into stage 5. So it was also called as retrolental fibroplasia. And some other causes like PHPV, POTS, or fever. So in all this, irrespective of what the diagnosis turns out to be, early referral is the key. Coming to ROP or retinopathy of prematurity, this is the leading cause of visual impairment and preventable blindness in children in the world. In India, we have a high birth rate, and of all the births, preterm births are supposed to be 1 to 2%. Now, because of our pediatrician colleagues, the survival rates are very good, even with premature babies. And so the burden of ROP is increasing and is likely to increase further. Also, the screening programs in place still lack 100% coverage. As we all know, ROP, the most important risk factors are gestational age less than 30 weeks and when the birth weight is less than 1,500 grams. So if we see the magnitude, in India almost we have 3.5 to 5 million, that is almost 50 lakhs prematures who are born every year. Incidence of ROP, that means they get changes of retinopathy of prematurity, may be seen in 37 to 54%, and at least 7 to 15% of them will need some form of treatment. So this is a pretty huge burden. Coming to pathogenesis, initially it was thought that it's just pumping high oxygen which causes ROP, but now we know there is an interplay of many factors. So when there are periods of high supplemental oxygen, it can reduce the angiogenic factors, and this delays physiological retinal vascular development. High oxygen can also damage the existing normal vessels, and this compromises development of vascularity, especially as we go towards the periphery of the retina. Now, once the retina is avascular, the avascular cells secrete VEGF, vascular endothelial growth factor, and this leads to formation of abnormal vessels. This is similar to what also happens in adult diabetic retinopathy or after vein occlusions. Once neovascularization develops, these new vessels can bleed, so we get either retinal or vitreous hemorrhage. And when they start getting a fibrovascular component, it leads to traction, and that leads to detachment of the retina. So this is very important both for pediatricians and for general ophthalmologists. As far as screening is concerned, which babies do we screen? So all preterm neonates who are born at less than 34 weeks of gestation and who have a birth weight less than 1,750 grams. In India, we take it as 1750, in Western countries, 1500. And all babies who are 34 to 36 weeks, who may have a birth weight of 1750 to 2000 grams, but if they have any additional risk factors for ROP. So these include various systemic conditions like anemia, septicemia or infections, respiratory distress syndrome. Then if you have twins, need of blood transfusion, poor weight gain in the baby, or intraventricular hemorrhage. When should the screening be done? So first examination should be done not later than 4 weeks or 30 days of life when infants are born more than 28 weeks of gestation age. If the infants are born at less than 28 weeks, nowadays we see very commonly babies of 26 and 28 weeks also, they survive because of excellent neonatal care. And if birth weight is less than 1200 grams, then they should be screened slightly early. Don't wait for 4 weeks, but screen them at 2 to 3 weeks because sometimes they go into what we call as aggressive ROP. So these need slightly earlier screening. So rule of thumb is any eligible baby for ROP screening must be screened before 30 days of life. So where is the screening done and who should be doing it? This is done by a trained ophthalmologist trained for ROP screening. Usually what we use is indirect ophthalmoscopy with depression. Again, when there is a lack of trained ophthalmologists, we have telemedicine coming into the picture, and we have many centers now who have excellent telemedicine facilities to screen, and then once the babies are detected, they can be referred to a higher center. So in this case, we have technicians and optometrists who are trained in RETCAM imaging. Once these images are taken, they are interpreted by an ophthalmologist, and then the babies who may need further screening or treatment, they are called to the higher centers. So we can screen in the NICU where babies are admitted, or once they are discharged from the NICU, we can check them in the ophthalmology. We have to dilate with a slightly dilute, not what we get commercially, what we use in adults, but it is slightly more dilute. So phenylephrine 2.5% and propicamide 0.5 or 0.8%. We use topical anesthetic and pediatric speculum like Ferguson speculum. When we examine, we are facing the quadrant which we want to examine. So we stand diagonally opposite. And a scleral depressor, infant scleral depressor is important to visualize the extreme periphery. Now we have digital imaging with RedCam. We also have some low-cost cameras like Trinetra. And we have certain innovative devices of late, like we have this handheld device, what you can see, where we have a 20D lens, we can image it, and a smartphone is attached, and we can click photos on the smartphone. So these are certain low-cost options for documentation. Documentation with photography is becoming more and more important now, especially in this era of litigation. Next is how do we document what we have seen and communication with the parents. So we record it on an ROP sheet with a diagram which shows all zones and stages. I'll show that in the next slides. One copy of this remains in the NICU and one with the ROP treating team. And we have images, RedCam, which we can store digitally. And we have a card which is given to the mother when we discharge the baby. And date and time for the next OPD visit has to be written. Again, it has to be verbally told to the parents. So this is important so that they know, don't miss the follow-up. So coming to the zones, what you have to remember now, the zone 1, we have optic disc at the center. We are all used to always drawing the fovea at the center, but now we have optic disc at the center. So we take the distance from the disc to the fovea, we double this, and that is the radius of the circle. This makes it zone 1. A circle concentric to this, where the nasal perimeter is the nasal ora serratar, is the zone 2, and the remaining temporal crescent is the zone 3. So these are zones of ROP, and when we draw our findings, when we screen a baby, we have to label all the zones as well as clock hours. So 1 to 12 clock hours. Each clock hour obviously is 30 degrees if we consider a circle of 360 degrees. So what are the phases and stages? In phase 1, what we see is compromised physiological vascularization. That means we have retina getting vascularized up to a certain extent. Beyond that, the retina is avascular. So the vascular and avascular portion is separated by a line called as demarcation line. This is the first stage. This demarcation line now becomes thicker. That means it gains some width, height, and volume, or it becomes three-dimensional when we call it as a ridge. That is stage 2. In phase 2, where there is vasoproliferation, we have abnormal new vessels which start growing on this ridge. And this goes perpendicular to the retina into the vitreous. So it is called as extraretinal fibrovascular proliferation. In phase 3, where we start getting fibrous tissue or fibrovascular phase, it can lead to stage 4 with a partial RD or stage 5 with a total RD. So this is the classical textbook diagram showing demarcation line, ridge, then stage 3, where we have extraretinal fibroscular proliferation and a detached retina. Coming to actual photographs, we can see the white line in the photograph above, that is the demarcation line. We can see that the vascular retina and avascular retina junction clearly. This then progresses to stage 2, where we have a ridge. Again, this has to be appreciated with binocular vision, stereoscopically, so we can make out that the ridge has certain depth. Stage 3, where we get on the ridge extraretinal fibrovascular proliferation. Stage 4, this is subclassified where either the fovea is attached, when it is called as stage 4A, and if the fovea detaches, that becomes stage 4B. Then stage 5 is total RD, which is again subclassified. So in 5A, optic disc can be seen, in 5B it is not seen, and in 5C, we start getting anterior segment changes like posterior synechiae or iridolenticular and iridocorneal adhesions, sometimes even a corneal opacity. And certain specific entities, what is plus disease? So in here, we get marked dilatation as well as tortuosity of the retinal vessels associated with some amount of vitreous stage, an engorged iris, and a rigid non-dilating pupil. 3+ again is another terminology added recently. So this is having some amount of dilatation and tortuosity, but it is less than plus disease. So now it is considered as this is a spectrum. We have normal vasculature, then we get pre plus, and then it progresses to plus. So this is a continuous spectrum and not a separate entity as such. So we had the international classification of retinopathy of prematurity. This very first classification was in 1984 when a group of experts on ROP met and formed the first classification. This is basically all the zones and stages which we just saw in the previous slide. Certain modifications were made in the second ICROP 2 classification, that was in 2005, where they described pre-plus as well as APROP. So what is APROP? This is aggressive posterior ROP, which is again having marked plus components and some other factors. Then ICROP 2005 was again recently modified last year, and this is now ICROP 3 classification. So this is to include certain new modalities, both of imaging as well as new treatment modalities, that is the anti-VEGF injections. So the latest classification, what we got last year, is ICROP 3. So they have added one more zone, or they have divided zone 2 into two, posterior zone 2 and anterior zone 2. Posterior zone 2 is closer to zone 1, and obviously it is more important and more worrisome because to some extent it mimics zone 1. So this was the first change which was considered in ICROP 3. Second was this notch. So what this photograph shows is we have avascular retina going into the macula or going into zone 1 in the form of a notch. So this is incursion of the avascular area from zone 2 into zone 1. This has got special significance because again it is a bit more severe. And another thing is when we document our findings, we should not just write it as immature retina. We have to mention that there is incomplete vascularization till what zone? For example, incomplete vascularization till zone 2. So another change is what was the aggressive posterior ROP is now called as AROP. So the new terminology is aggressive ROP instead of APROP. And all previous terms like rush disease or fulminant ROP or type 1 ROP have all been replaced. So what is aggressive ROP? This has certain specific features. It is more seen in the posterior zones. Sometimes there is just a deceptive featureless junction. So this can be missed or it is difficult to make out. And there is flat neovascularization which can progress very rapidly, causing fibrosis, and we can get detachment within a few days rather than 4 to 6 weeks. So this is something which can progress very, very fast. And sign of early aggressive ROP is AV shunting and dilated vascular loops. So when we screen, what are the decisions? Either no further screening is required. That means either there is complete vascularization till the aura or it has regressed. If further screening is required, we have to write specifically whether it is in a few days, 1 week, 2 weeks, depending on what is the zone and stage. And in some cases, when urgent treatment is required, we have to mention it. When do we stop screening these babies? So when full vascularization of the retina is complete till ora serrata, which usually happens by 40 to 45 weeks, or ROP findings are there, but they regress. Then we can stop the screening. Coming to treatment, we have 3 different modalities: laser, the anti-VEGF injections, and surgery. Laser is usually done on the same day or screening, same day or as early as possible. Anti-VEGF injections have certain specific indications, like it is given in aggressive ROP, it is given when the pupil dilates poorly or there is rubeosis, or in cases of vitreous hemorrhage. Surgery can be done for stage 4A and 4B. So if we just have peripheral traction with an attached macula, sometimes just relieving the peripheral traction by a buccal helps. And in 4B, if the fovea is detached, we can have lens sparing vitrectomies. Stage 5 also is operated. Results are poor universally. In fact, some centers have stopped doing surgeries for stage 5 altogether. So what are the indications for laser? Previously, in the very first classification, there was this concept of threshold ROP. So this is something which where the definition is typically asked to postgraduates. So what is it? This was a condition where there is a 50% risk of RD if it is left untreated. And it is more than 5 contiguous or 8 cumulative clock hours of stage 3 in zone 1 or 2 with plus disease. And we have pre-threshold was similarly defined. So then after the changes in classification, they found that treatment at a stage earlier than threshold also improved the outcomes. So then pre-threshold, some of the babies in pre-threshold was also treated. So they were divided into two types. Type 1, which was high risk, which was also treated with laser. And type 2, considered as low risk, we can wait and watch closely. And if it goes into high risk, we start treating with laser. So laser is done with indirect ophthalmoscopy, usually in the NICU setting where we have a neonatologist or pediatrician monitoring the baby. During laser, we can get the baby having spells of bradycardia or apnea. Sometimes corneal edema develops. So we aim to finish the laser session as soon as possible. The faster we can finish, the better it is, both for the baby and also it reduces chances of cornea developing edema. Sometimes if we cannot complete in one session, we can plan a second session of laser. VEGF inhibitors is the new weapon in the battle against ROP. So we have many trials where Lucentis and Avastin both have been used. Preferable setting for giving injection is always the operation theater because we can maintain sterility and give it under microscope visualization. In ICU setting also it can be given, but then again there are some chances of endophthalmitis, or we can even injure the crystalline lens. Surgery again requires a dedicated team, an ROP surgeon along with neonatologist and anesthetist. These are difficult GAs. As I already mentioned, for stage 4 for peripheral traction, we can do buckling, stage 4 be lens sparing vitrectomies, and in stage 5 lensectomy with vitrectomy. 25 and 27, which are very small gauge, have been proving highly beneficial for such surgeries. ROP does have long-term sequelae, so the follow-up of these babies continues for quite long. Later on, even at elder age, they can develop either squint, some of them amblyopia, many of them develop myopia. Some of them can develop detachment, latent detachment quite later on. This is where what was originally listed as a peripheral avascular retina. So in some, this PR or peripheral avascular retina later on develops lattices and holes and can develop a detachment. So long-term monitoring is essential to keep a watch on all these sequelae. Thanks.
Excellent. Can you have the mic? Excellent presentation, Dr. Leukocorya. We have another one lecture coming up by Dr. Pradeep Deshpande. The squint, why and when to operate, amblyopia, lazy eyes, preventive, practical tips, innovations and simple solutions like vision gain. Over to you, sir. Any questions in the audience? Please pass it on to me so we can ask the international panelists, which are going to shortly start this lecture. Let's make it more interesting. As you open up the presentation, anybody would like to ask a question to the faculty that we have. Dr. Leukocorya is very well covered the retinopathy of prematurity. At the pediatrician level, you are the first contact with the child. The neonatologist, of course, has a big role to play, as rightly said by Dr. Leukocorya. And also Dr. Pradeep Deshpande in his first lecture very well summarized what exactly you have a big role to play, because the first contact is the pediatrician. So, like the fifth hormone, what we have well covered regarding acrocystitis, the congenital epiphora that you have, how to treat, how to go about it, when to refer. Timely referral can save the child out of agony in life. Amblyopia. The patient has got big glasses and all, and the vision is not yet good. It's unsteady vision, then he has got severe photophobia. These are the reasons I think instead of treating at your level, it's nice to refer to a nearby ophthalmologist or colleague, so the child gets benefited at a very, very early stage. So, the ready presentation, sir?
Yes, yes.
Yeah.
Thank you. Thank you for your excellent comments, sir. I'm highly obliged. Thank you very much. Okay, sorry. Yes. Another important topics that I'm going to cover. Number one is amblyopia, the lazy eyes, and number two is strabismus, commonly known as squint. These two topics I would like to cover because there is a major role of the pediatricians. They are I always call them first frontline defenders, and they are the best counselors. They can tell the parents properly. Otherwise, all the children of amblyopia and strabismus, they come to us at a very late stage, and at that time it's very difficult to tackle those things. Amblyopia, commonly known as lazy eyes, is not a disease. It is a disorder. It is a major cause of subnormal vision, and it causes a lot of adverse effects on the visually related quality of the life of that child. In almost 2 to 4% of the world population in world, approximately 2% in the United States, 3% in Australia, 4% in India, and almost 8% in developing world. This is the shocking prevalence of lazy eyes. And they are thrown out of competition at different interviews just because the one eye is having 2 or 3 lines less. So amblyopia, as far as the definition is concerned, either it is a unilateral or bilateral best corrected visual acuity without any visible cause. Eyes are good, but the vision is less. In most of the refractive amblyopia, we can say, दिखने को अच्छे लेकिन चलने में डब्बू. Eyes are well developed, don't worry, in refractive amblyopia. So, but recently they have come across certain researches that it is a binocular dysfunction. Even if one eye is having low vision, the other eye, which we call it the normal eye, may be having 6/6 vision. But that eye also has certain deficits, visual function deficits. So, what are those deficits? It is not only the visual acuity is important. That means the child has got 6/6 vision or 6/12 vision. That is not important. There are, all the postgraduates should note all these points. These are very important. All the children of amblyopia, they are having multiple visual function deficits, like inability to read the crowded letters. If a letter of a particular size, suppose 6/12, the child can read. 2 letters apart of the same size, the child can read. But if the letters are crowded together, child is unable to read. Oh, I can't read, which the child will say. So I have developed a simple computerized program for that. This is my own patented thing, that we can dissociate these words gradually by every 1 millimeter every time, by 1 dot. And when the child will read that particular crowded letters by dissociating the words, that is the vision. That means 6/12 by 5 dots. And next time, after giving certain games or any amblyopia treatment, when the child will come back, the child will be able to read with 1 or 2 dots only. That means there is a improvement by 2-3 dots. So you can measure the improvement by millimeters. That is one of my important publication. And another important thing that deficit is that the children, they are unable to, the inability to see the contrast sensitivity. That means the contrast objects or the colored object, contrast colors, they are unable to recognize. Then they are unable to recognize the depth perception. Binocular reflexes are also less. Then they have subnormal stereo acuity. Then there are so many multiple things, convergence, deficiency, movements and everything. And such children, when they go for class 1 jobs, the precious, meritorious students, they will come back. They will be thrown out of competition. And they will be labeled as unnecessarily labeled as a visually unfit. So the parent at that time, at the age of 20, 25, it's very difficult to treat that amblyopia, the laziness. So for that, you must understand the different visual development, the periods of visual development. The development of visual in relation to lazy eyes is critical period of visual development that I have already told you. This is the critical period begins just after birth and has a peak time after birth up to 2 years only. 1 to 2 years, 90% vision develops. And during that time, if the child is not using any glasses, not using any contact lenses, or there are certain obstructive lesions like congenital cataract, ptosis, corneal opacity, then the visual pathway will be obstructed and the vision will not develop. So we have to, these are all ocular emergencies. We have to tell that parents that go to the doctor immediately, get it corrected properly or urgently. These are all emergencies. Otherwise, the amblyopia will settle permanently and it will be difficult for you to correct the vision. And the child will continue with a very low vision throughout his life. Then nowadays they say that there is sensitive period also. Up to 7 to 12 years, yes, there are good chances of improvement of vision in amblyopic children. There is one more period is there. That is the plasticity of visual system. As per recent studies, the visual plasticity helps to improve the vision till there is the presence of anabolism or determination to perform the amblyopia work. So that's why it is said, one academician said, what he said, this is exaggeration, but it is still there. The management of amblyopia should be started when the head is born, but the body is yet to be delivered. Oh, what a great thing he has told. And it's really true. So what we can do, our ancestors used to do that. As soon as after the birth of the child, they used to put a sandwa, 2 amber-colored dolls over the cradle of the child. These 2 dolls used to move slowly, not the new one that is moving continuously like that. Only 2 amber-colored dolls can help even in normal babies to develop the binocular reflexes and the vision better. So this is the time of 12th day onward. 10 days there is a quarantine. Nobody will allow you to enter that child's room. But on the 12th day onward, Barsa day, we call it naming ceremony day. On that day, you can start treating the baby and you can gift a colorful sandwa to that child. Instead of giving all these different shirts, these clothes to that child. Best way is to give these things. So dear friends, don't forget to gift a colorful sandwa at the occasion of naming ceremony, at least as a prophylactic measure. It will not allow the amblyopia to settle. Our aim is to utilize every day of critical period. So this is the very simple trick. And what are the common precipitating factors? Number 1, refractive amblyopia. If the parents are having minus number, plus number, if both the parents are 1, or if their grandparents are having refractive errors, the child is likely to get. Everything is heredofamilial. Color, complexion, all the things, even different diseases, they are genetic, familial. So in all these cases, all the children should be subjected for proper screening for assessment of refractive errors when you put that child, enroll that child into a nursery KG school. Otherwise, they will make so many mistakes. slow reading and writing will be there. Then in all the cases of stimulus deprivation, amblyopia, congenital cataract, corneal opacity, and ptosis, all these cases, these are emergency. You have to operate the child as early as possible. Well, after giving the specs, we can wait up to 12 weeks by giving perfect refractive error. And then wait till, even if there is amblyopia, mild to moderate. So you can wait for 12 weeks, and then if that vision doesn't improve, in those cases only you can start your specialized treatment, maybe patching or any computer games or anything. So, and tell the parents all the time that don't bother that there is a -2 sphere, -2 cylinder, but tell them to look at the column of the vision. This is the last column. I have seen with many ophthalmologists, there is no column of vision also. Very interesting. But tell them, stress them that the parent should see all the time how much is the vision, whether it is 6/6, 6/12 or 6/18, whether it is improving or not. Don't bother about -2 cylinder or -2 sphere. Our great surgeon, LASIK surgeon, Dr. Vittal Sato, can remove those particular sphere cylinder within few seconds by performing a LASIK. But at that time, you will not be able to improve that vision. The amblyopia will settle permanently. So all the time, tell them to bother about the column of vision in their prescription. Okay? And follow the basic things. Firstly, present a clear retinal image. Then secondly, is to make the child to use that spectacle or contact lenses. In anisometric cases, if there is a high sphere, more than 3 diopters, in those cases, contact lenses are compulsory to equalize both the images. Otherwise, the child will use only one eye, which is better or dominant. Otherwise, the other eye, which has high cylinder or high sphere, more than 3 diopters, will remain lazy all the time. We prescribe contact lenses within a year also in such babies of anisometropia. And third important thing is that be positive, attentive, and go for amblyopia treatment. What is the amblyopia treatment? Commonly, there is the gold standard. Everybody tells that gold standard is patching. All the children specialists here, all the ophthalmologists here, they know what is the status of patching. The child will be most reluctant to use patch. You will not like that. And the parents and the doctors will all the time go on using for 6 hours, 12 hours, all the daytime, all the waking hours. Is it possible? Practically, that is not possible. There are 2 important things why I am against of patching. Number 1, the compliance issue is great. The child you will get frustrated and he will not obey your orders. Number 2, after reviewing patching, if the vision improves for a line, 2 lines, 3 lines, after 6 months, it is very slow, progressive. This is a passive therapy. So there is a gradual increase of vision. Definitely the vision improves. Patching has definitely some role. But as soon as you remove the patch, if we don't do any proper tapering of patching, the patching time, the vision will again go back to its original position, known as regression of the vision. This is very common. Almost 25% children will come back to you with a regression. So there is a definite advantage with this active era of treatment where the eyes as well as the child both are actively involved. These computer games can be played over the monitors. You can see the boy is using a glass. That glass is not a simple glass. It is an electronic occluder. So automatically one eye gets occluded for some time, then the other eye gets occluded. This is known as AMLAB glass, and such glasses, they will be happily, they will use it instead of patching. And I have covered that monitor also to get a better effect. So, but nowadays, we are coming to a different thing now. Best thing is to use 10 inches, almost equal to a 10 inches tab, where we can play the computer games. And this is the era of now. Every child is nowadays, he is having a tab for their school education also. So you can try use that particular tab to this particular girl. She came to me with just a 1 meter vision at the age of 12 years. And after playing the game just for 1 month, her vision has improved up to 6 meters. Such miracles will definitely happen with eye-hand-brain coordination games. These are very simple tricks and very simple things. So for last almost 15 years, I have developed basic preventive games, and more than 10 children, they are using these games online as a lazy eye master game. Then these are specially designed for the high risk babies. Many children, the parents are having high refractive errors. There are so many reasons why their high risk is there. In high risk babies, you can start using, you will not allow that amblyopia to develop. Then specific rainbow games is one of my paper again. It is said that the macula has different types of cones. For every color, it has a different cone. So why not to treat every cone with different colors? So multicolor stimulation, or I use it with 7 colors. All the games, my games are with multicolor, and that improves the vision very fast. Then one more thing, important thing, what I have done, in all astigmatic, the cylinder is very high in children. The astigmatism, we call it as astigmatism, where there are 2 meridians. One meridian is focused on the retina, other is focused either in front or behind the retina. In all meridional amblyopia cases, these high cylindrical cases, even if you give a patch, or even if you give a glass, nothing will happen, because one meridian will be always lazy, which is defocused, chronically defocused. So in those cases, there is only one solution, and that is my patented thing, that you go in that particular meridian, lazy meridian, and stimulate the lazy neurons. You can see that on Google. There's a paper there. So we treat these with astigmatic axis video games. And last but not the least, the patching has still good scope, especially in anisometric children where there is a lot of difference in the vision. You can use patching, but only in the privacy, not in front of the relatives, not in schools, not in gatherings. Tell the child to use that patching only in his study room, and then he will definitely use that. Or you can start using that particular glass, electronic glass. And the combination of active games and passively, you can give patching in that particular room, study room, is the best option in such cases. But most of the cases, as it is a binocular dysfunction, binocular games, they are gaining popularity day by day. Hundreds of people, they have come out with that binocular games are very useful. And I have also seen during practice of my 15 years that these games works beautifully. The children, they play all the time game. And the greatest advantage of these games is that there is no regression. Because intermittent gameplay will prevent that regression, prevent that relapse. The vision will not go back. It acts as a booster dose. So that is the best thing with active games. And I have developed certain basic games for after the age of 2 years, See that small baby is using those games then she is very happy with those games. So treat amblyopia before it settles. Preventive as a prophylactic thing. Don't allow the amblyopia to settle. That is my concept. All the time I talk in different types of conferences everywhere. Then the rainbow games. And now I have come out with some different games now. There are multiple visual deficits in amblyopia. So now my games will be concentrated on a particular deficit. If the child has a contrast sensitivity problem, then for that child, this particular wheel will go on rotating and the child has to tap a particular percentage of that particular color. And practice makes a man perfect. So all the children, they will develop proper coordination, and they will develop binocular reflexes, then the stereo acuity. This is my axis game. And all these different things, this particular tab which I had told you, the tab is having you can assess the vision with different new things, all the pictorial charts and the measurement of the amblyopia in millimeters that you can measure on that particular tab. And that tab is having for the games for the vision also, improvement of the vision. So that was inaugurated by the President of American Academy. And it was rewarded by our past President, APJ Kalam also. But don't forget, as per American Academy of Pediatric Association and Canadian Academy and myself also, no screen time of any kind is allowed for the babies below 2 years. And not more than 30 minutes at a time. If they are going to use after 30 minutes, the children are going to get some dryness, headache, some visual problems or all these things. So mind well. Keep a timer on your tab. After 30 minutes, automatically it will shut down, at least for 10 to 15 minutes. And then again, he can play for 3 to 4 times a day. And as per all PADIG group or amblyopia study groups all over the world, they say that the patching should be limited only for 2 hours in mild to moderate type of amblyopias, or 4 to 6 hours in severe types of amblyopia, not more than 6 hours. So these things will definitely you will be able to take care. And the smart mobile phones, be careful. The smart mobile phones will not be useful to improve the vision. On the other hand, they may cause dryness, then watering, and they have to concentrate on a very small, brighter screen, and they will hold it very close. So they will get addicted also. So again, the basic management, remove the basic cause, give the glasses regularly, and best corrected glasses. No tropicamide should be used, only cycloplegic drops up to the age of 12 years. Up to 5 years, you can use atropine. Up to 12 years, you have to use cycloplegic drops. And after that, in all amblyopic cases, you have to test the babies from a distance of minimum 4 meters, not just 3 meters, 2 meters. Everything now is going in a different way. But in amblyopia, that will not work because the accommodation plays a great role. Minimum 4 meters should be the distance. Actually, it should be 6 meters viewing distance should be there. Thank you. Last slide. Finished. Oh, sorry. I'll come back to the last topic. Hurriedly, within 2 minutes, I will finish. Strabismus. When and why? The surgery should be necessarily be performed in the early priority, not only provide a good look. Especially in cases of one-eyed esotropia, strabismus fixus, eccentric fixation, essential infantile esotropia cases, the surgery should be performed as an emergency as early as possible. Then considering this child psychology, even Dr. Dedia and Lam also, they told they have worked on that particular thing, that you can perform the surgery before treating the amblyopia also. Because classical teaching is that you treat the amblyopia first. But till then, psychologically, the child will get a lot of problems, frustrations, and squint surgery is a OPD procedure with the new techniques of a Fugo blade, then all different glues. You can operate these cases in certain lateral recti. We can operate as a sutureless surgery. The conjunctiva is also without any suture, just by using a glue, surgical glue. In lateral rectus also, we can operate all the 4 muscles at a time by some different new techniques, which will not perform, which will not be hazardous for that person. There won't be any medial rectus loss any time, or there won't be any anterior segment ischemia. And in all the cases, all the ophthalmologists should know that while performing the surgery of a child below 3 years, you must, because the children are unable to give you a good, they will not cooperate for a particular refraction. So in all the cases, you have to take that baby on a table under general anesthesia. When you try to perform the surgery, always do a refraction on the table. And that you can provide that refraction afterwards. A perfect refraction will definitely prevent the amblyopia. And you have to see the fundus also, call a retina person, see the fundus properly to rule out the possibility of retinoblastoma. Then repeated surgery is also quite safe. There is no danger, and with under corrections and over corrections are quite common. But with new techniques, with a lot of experience, repeated surgeries can be performed very easily. And there is one case I would like to tell you, that she was operated in US at least 2 times. Still she was having squint. So she came to me and I operated. She has sent me that particular photographs. So repeated surgeries 2 times, 3 times, 4 times, 5 times are also safe in expert hands. Don't worry. But you have to give 100% correction to that child, so that child will be able to move in the society, in the locality, or everywhere. You will move properly. You will get a good partner, life partner also. So perform the surgery till you can give the almost 100% result. Thank you very much.
Excellent take on the subject, sir. Very nicely covered in detail and in a very, very nice manner.
Now time to panel discussion. I invite Dr. Kaswara sir, who is president of Maharashtra Ophthalmical Society and is very dynamic ophthalmologist. Sir, please moderate the session.
Thanks, Victor. Thanks for the invite here. There are interesting questions which I'm going to ask the panelists. First one, I welcome the panelists online, Dr. Professor Subhash Dedia sir, Dr. Santosh Agarwal is the Vice President of the Maharashtra Ophthalmological Society, Dr. Rishikesh Mai, Dr. Shubhangi Bhave madam, Dr. Reenu Jainar, and of course our in-house faculty who are very much here. My question to Dr. Subhash Dedia sir. What is your take and what are your tips to the pediatrician? We have an august audience of pediatricians here in physical form. So what are your tips to the pediatricians? How the eye-wise, how they can help us? And what are your tips and thoughts, sir?
Sir, I think this topic has already been covered very well by Dr. Pradeep Deshpande, but I would like to give one tip only. That is, the pediatricians, they should occlude the alternate eye, because if there is risk of amblyopia, the child will resist occlusion of the sound eye. So that tip is very important for pediatricians, even for school teachers, and even for mothers at home. So if they will cover one eye, and if the child is having amblyopia and you are covering the sound eye, then the child will resist the occlusion of the sound eye. So that one practical tip I would like to give. Otherwise, Dr. Pradeep Deshpande has covered this topic very well.
Yes, Dr. Subhash has already told you a very important tip for the pediatricians. That if you see the child, if you try to occlude one eye, if the eye is having a good vision, he will never allow you to close that eye. Immediately he will pull your hand. That's a very important thing he has told you just now. And I would like to ask Dr. Subhash Dedia regarding the computer games or the different types of games for the treatment of amblyopia. What is his opinion?
Sir, I think you have covered this topic very well, and in cases of amblyopia, actually, we have done a thesis regarding use of these television games, and
Sir, we can't hear you. Just hold on. There's a technical glitch. The audience is just not able to hear you.
Can I answer that question, sir?
Said that yes, you all pediatricians should follow, as you rightly said, that there is, in case the child is just trying to avoid closing any of the eyes, that means that is the better eye, the other eye is the one which is affected. So it's time to refer quickly in time. Right, sir? That is what you are trying to put across?
Yes, sir. So basically, a lot of studies have been done regarding this use of mobile game, video games, and our own Dr. Pradeep Deshpande has devised very effective games for treatment of amblyopia, and these are basically, we have done a comparative study in which in one eye we have used in one group we have used only occlusion therapy, and in other group we have used occlusion and these television games, and the group 2 in which these games plus occlusion was used, the visual outcome and stereoacuity was better. So definitely these games are useful in treatment of amblyopia. However, this PEDIC group of studies, the latest reports, they don't found them to be very useful. So, but our experience with this is good, and we recommend this as an adjuvant therapy in treatment of amblyopia. And one thing Dr. Pradeep Deshpande has said about these liquid crystal glasses instead of patching, but only drawback with these is they are very costly, and the most of the patients, rural patients, they cannot afford these. So patching will remain one of the most important treatment modalities in treatment of amblyopia, sir, because that is very cheap.
Thank you, sir. Question to Dr. Renu Jain. She has joined in behalf of Dr. Mehta. You are as a pediatrician in UK. So yes, how do you go about this, that the topics we just discussed? Can you just briefly say what is your protocol that is followed regarding amblyopia, regarding squint, and of course ROP? In short.
Okay, thank you very much. I think it was very useful discussions, and Dr. Deshpande and Dr. Shah's presentations were very useful, especially the video game one, because I'm not aware of it being used. We still use the patch, and mainly, as Professor Dadia said, it's very cheap and it's cost effective. I think from my perspective as a consultant pediatrician in child health, what is important is that one is we don't miss, when we are focusing on the eye, we don't miss things like dysmorphism, like microcephaly, or any neurodegenerative condition, because you've got to think of the child as a whole. And the second thing is the screening part. We do have regular screening for eye. So one is at birth, we check them for any cataract, red reflex. Then we have everyone has a check. So there are universal screenings at 6 weeks, 6 to 8 weeks by the general practitioner, where we look for fixing and following. And then we have it at 8-9 months. Subsequently, the health visitor does it at 2 to 3 years. And the proper vision test by the opticians is done at 4 to 5 years, depending on the learning disability. I hope you all can hear me. So I think it's useful to have a screening test, which I think given the way the setup for health is in India, it may be a bit difficult because it's run in different cities, different states, it's managed differently. However, I think from my perspective as a pediatrician, universal screenings are always better because the pickup rate is high. But unfortunately, because of the limitation of resources, even in UK, we are struggling to get everyone have a preschool check by the orthoptist, because that will be a very good way of picking up amblyopia, just exactly what Dr. Deshpande and Dr. Dadea has said. So it was quite enlightening, and thank you for the invite. Dr. Mehta is in a board meeting. He said he'll try and join, but I'm the pediatric chair for Bapu, so he asked me this morning. Thank you.
Thanks for the quick answer and very nice. Thanks for joining in place of Professor Mehta. Dr. Deshpande would like to say.
Yeah, one postgraduate from government college was asking me regarding the role of pharmaceutical drugs like levodopa, carbidopa. So I would like to ask Dr. Subhash Dedhia
Sir,
use of carbidopa and levodopa.
a lot of studies have been done regarding this use of levodopa, carbidopa in treatment of childhood as well as adult amblyopia. And some studies, they have been found to be useful. In others, the result have been equivocal. But in my opinion, the current trend is they should only be used as a adjuvant therapy only in cases of if there is very severe amblyopia in one eye. So during the initial periods, there is so that because it speeds up the recovery, visual recovery. So they are not a primary drug for treatment of amblyopia, and they can be used in selected cases with very severe amblyopia, so that during early phase, when we pass the good eye and the child has vision of 2/60 or 3/60, so there is they speed up the recovery, but ultimately once you stop these drugs, the effect goes. So I think there was one article also recently in the post that we have wasted so much time in studying these drugs, and now that era should be ended.
Thank you, Vinesh sir. We are very much thankful for you. One more important question I would like to ask you. That you are traveling all over the world as a faculty. What is your opinion about the refractive surgery in children?
Dr. Deshpande, there are a lot of studies regarding use of refractive surgery in adults as well as in children. And those who are proponents of the refractive surgery, they will keep on propagating the refractive surgery. But we have also done a thesis at our center, and in my opinion, the refractive surgery should be tried only in desperate cases in which conventional therapy has failed, of only adult anisometropic amblyopic cases. I don't recommend this refractive surgery in children.
Thank you, sir. Thank you very much.
Question to Dr. Dedhia, sir. Is there any fellowship in computer games for the management of amblyopia in foreign countries? Any idea? This is from Dr. Zarade, is Associate Professor of Vijay Medical College.
I can try and find out. One of my batchmates is a pediatric ophthalmologist in Manchester Royal Eye Hospital.
Okay.
So I can find out if there's, and
Yeah,
I can
that'd
get
be nice
back
of
to
you, ma'am. If you can relate and send us a mail or this thing, we'll try and share it on the chat box. please try and do it.
Sure.
And,
Can I ask?
Sorry.
Sorry, can I interrupt and ask one more
Please,
question?
ma'am.
Thank you.
I have put it in the chat box as well for Dr. Deshpande. You had suggested that maximum they shouldn't go on the video games for half an hour at a stretch.
Yeah.
But how many times can they go on for it? And
At maximum 3 to 4 times a day, or as per the severity of the amblyopia. In mild to moderate, just 2 hours per day is enough. But for severe amblyopia, you can go for 4 to 6 hours also.
okay,
But definitely with the gaps.
thank you. That's helpful.
We have the target audience here as pediatricians, the August audience who are present here. Keeping that in mind, I would like each of the panelists. First, I would like to start with Dr. Rishikesh Mai. Your tip to the pediatrician for timely referrals regarding each of these cases. What is your take, Dr. Rishikesh?
Good evening, sir, and thank you for inviting me for this August gathering of.
A little loudly.
Am I audible now?
Hold your this thing a little closer and speak a little loudly.
Okay. Am I audible now?
Very, very low voice.
Okay, just a minute.
We could hear Dr. Renu very nicely. Similarly, I think we can put the volume full. Come a little closer and speak a little louder. So you'll be able to put across the message.
Rishikesh Mai is a very reputed consultant in pediatric ophthalmology, strabismus, from Nagpur. He is an executive member of the Pediatric Association of All India. And there was one question from audience that they want to ask a particular question to Dr. Mai, that what are the common causes of a congenital cataract? And what are the recent new investigation we have to perform for that before surgery? Rishikesh, can you hear?
No, he's not. As Rishikesh has a problem, we'll go to another panelist, Dr. Santosh Agarwal, is the Vice President of the Maharashtra Ophthalmological Society. Your tips of regarding ROP to the pediatricians, Dr. Santosh Agarwal.
Santosh Agarwal is doing a lot of work on
ROP.
Aurangabad on ROP.
That is why I asked him.
Hundreds of cases, treated hundreds of cases of ROP with a group practice.
Thank you very much,
He is the Vice President of MOS also. Yes.
Thank you very much,
Yes,
sir.
Santosh, a little louder.
Thank you very much, sir, for giving
Come a little closer. Come a little closer. Louder.
Thank you very much, sir, for giving me opportunity. Actually, ROP is a neglected topic for all, for pediatrician as well as ophthalmologist and for others also. So the incidence of ROP blindness is increasing in India just because of the 2-3 reasons. One is lack of awareness among all these specialty groups like pediatrician, ophthalmologist, and ROP experts as well, and patient mainly. And second is there is a high risk of ROP nowadays just because the contemporary neonatal practices have improved a lot and the babies are surviving, and that's why the risk of ROP is also escalated. So that's why we need a team approach to this problem, and we have come out with a ROP screening project, that is Arambha ROP screening project, and two vitreoretinal surgeon and one pediatric ophthalmologist. We have come together. We have purchased a wide angle imaging or fundus camera, that is Forus Neo 3 Netra camera, that is an indigenous camera. And we started our work 4-5 years back, and till now we have almost crossed 5,000 to 6,000 babies we have screened, and around 300 to 400 babies we have treated, and we are covering 8 districts of Marathwada, part of Vidarbha and Khandesh, and we desire that this project.
Thank you, Santosh.
Santosh,
Wonderful.
because your voice is not coming very clear.
Your voice is not clear, that's why we are interrupting. And
Am I audible now?
I would like to ask one question to Shubhangi Bhave. Shubhangi Bhave is one of the eminent trapeziological disease surgeon, as well as amblyopia. She is the vice president of All India Trapeziology and Pediatric Society. And there is one question for her, a special, how to differentiate, there is a differential diagnosis of sixth nerve palsy.
Good evening, everyone, and thanks for the opportunity. The differential diagnosis of lateral rectus palsy in children, most of us get an referral as a sixth nerve palsy in a child turns out to be a Duane's retraction syndrome. Duane's retraction syndrome is a congenital cranial disinnervation syndrome. So basically, sixth nerve palsy is not so common in children as the Duane's retraction syndrome, and certain salient feature which distinguishes a sixth nerve palsy from Duane's retraction syndrome is, in a sixth nerve palsy, the primary position deviation will be in accordance to the deficit of movement. So if the movement is largely affected, then primary position deviation will be large. But in Duane's, the primary position deviation may not be there or may be very little, and still could be accompanied by a large restriction in movement. So that is a common mistake which is done during referral of a sixth nerve palsy. The other features which diagnose Duane's retraction syndrome are the palpebral aperture changes which occur in adduction, then narrowing of the globe in adduction with upshoot and downshoot of the eye in adduction. So basically, these are the important features which we diagnose clinically.
Thank you very much. And please remember her words that you have to differentiate all the time with Duane's retraction syndrome, because they have many similar things in both the things as a sixth nerve palsy. Yes.
Welcome, Dr. Ramesh Mehta, sir.
The great president of Children's Royal College of Pediatricians in the United States, and the president of Bapu also. Yes. Welcome, Dr. Ramesh.
Thank you very much. Can I start?
For you. There is one question. For you. A specific question. That is there any scope for any post-graduation or fellowship in the United States, UK, or anywhere in the world?
Okay, good evening from rainy and cold London. It's a great pleasure to be there. May I start by thanking my colleague, Dr. Renu Jainer, who agreed to come in at last minute. And she has, I hope, answered some questions. She is absolutely fantastic pediatrician in Birmingham. Thank you also to Pradeep Deshpande for inviting me. I know he has been my classmate and a friend, but what I'm going to say is not just because he is a friend, but I've known him as a very passionate, sincere, and honest ophthalmologist doing the best possible work for children. So thank you, Pradeep, and best wishes. Now, to answer your question, you know, my organization, which was started 25 years ago, called British Association of Physicians of Indian Origin, or Bapu, is one of the biggest organization in United Kingdom, and we are doing a lot of work in India as well. So there are about 65,000 Indian doctors working in the UK National Health Service, and all of us of Indian origin, our heart is still in India. So we always try and see what we can do for our colleagues in India. One of the branches of Bapu is called Bapu Training Academy, which is now supporting recruitment of doctors from India in all specialties. So there are two types of projects that's going on. And let me clarify that Bapu Training Academy is not a recruiting agency, but we do this as an international fellowship program. So the first one is called 2+2 project, where we recruit doctors who are unable to get postgraduate qualification or post-graduation seat in India. These people are picked up by us. We train them for 2 years in India. So we have a lot of partner private hospitals where they are given a job, paid job for 2 years, during which they also get training. After 2 years, they are brought to UK for another 2 years of training. It's called 2+2 program. It is on Bapu website. The second program, which is called Fast Track program. This is for those ophthalmologists who already have postgraduate qualification. If they want to come and work in UK, and there is a big shortage at the moment, so there are a lot of opportunities, and they can contact us. They need only 3 months of induction. They need to pass English language test, and they need to be registered for one of the postgraduate programs in UK. And they can come here straight. They can stay here for as long as they want, 2, 3, 4 years, and then they can go back or stay on, and they get very good salary. So there are lots of possibilities, Pradeep, and all this information is available on the website.
Thank you, Ramesh. You are doing a lot of social work also all over the world. Great, hats off to you.
Thank you.
And all our postgraduates and other doctors will take advantage of your all these help.
Yes.
Even I would like to enroll myself also. Thank you.
Fantastic, Dr. Ramesh Mehta sir, for joining. Of course, we were waiting for you, and Dr. Renu did answer the questions on your behalf. It was nice. We have a question for Dr. Rishikesh. I think your technical testing is solved. Otherwise,
am I audible?
Yeah, Rishikesh.
Yeah, can you repeat the question actually?
Yeah. I just asked you regarding your tips that you would like to give to the pediatrician during this, and of course the investigation for congenital cataracts. What is the anything at the moment which they should do?
Any recent investigations for the different causes of congenital cataract?
Congenital cataract actually, unfortunately, in our country happens to be more in people with lower socioeconomic strata, which have lesser access to medical facilities in their town or around. So basically, congenital cataract is associated with many conditions, in intrauterine infections like torch agents, especially rubella. So test for rubella needs to be done. Certain metabolic conditions like galactosemia might be associated with this congenital cataract, as well as certain genetic disorders like Loeys syndrome or very rarely Down syndrome. But in our country, trauma happens to be one of the principal causes of congenital or especially cataract in early childhood. Almost 50% of the times, if there is no trauma, you might not be able to find out the exact cause, whether it is metabolic or genetic. But thorough investigations and blood tests are necessary to find out these causes, because many a times the congenital cataract might be associated with certain systemic conditions, like for example in rubella, it might be associated with heart problems or valvular heart diseases, congenital as well. So it's better to do a thorough investigation in these cases to find out the various systemic associations of congenital cataract. And obviously all cases will need surgery and visual rehabilitation, which you have pointed out earlier as well.
Very nice, Dr. Rishikesh. We are now about, as we are running short of time, we had a lot of technical glitches. So I thank the online faculty and the panelists who have joined on behalf of the Akash and the Maharashtra Ophthalmological Society and the Pune Pediatric Association. They have been part, and there has been excellent talk by Dr. Deshpande sir and Dr. Nitan Shah. Before I call it a day, I would like to call upon Dr. Seema Satav to give a vote of thanks. And thanks each one of you for joining online and being with us till so late in this and having a very fruitful discussion, mainly keeping the
pediatricians point of view. Over to you, Dr. Seema Sato, please.
And there is a lion's share of entered pharmaceutical also in this arrangement. Thank you.
Yeah, Seema, people are waiting for you. In the meantime, I would like to thank Dr. Renu Jaina, Dr. Ramesh Mehta sir, and Dr. Rishikesh May, Dr. Santosh Agarwal, and all the rest of the faculties as Dr. Seema Sato takes over. Yeah.
Good evening, everyone. Before vote of thanks, I would like to ask Dr. Sato to please come here and felicitate our great speakers and panelists. Dr. Deshpande, sir, please come here. Dr. Sato, please felicitate him. Dr. Nishan Shah, sir, please. Our panelist, Dr. Jignesh Pashwala, sir. From Endor Pharmaceuticals, there is one more felicitation. Actually, as doctors, we always promote fitness, and now so a few doctors from this area, from Vimanagar. Okay, fine. I am very humble and honored for giving closing remarks and vote of thanks in such a distinguished, intellectual, stimulated gathering. I thank all guest speakers actually for sharing their such a great knowledge and research with us. I thank Dr. Pradeep Deshpande sir, Dr. Nitan Shah sir. Then I thank our great panelists for making this event graceful by their presence, online presence, and here Dr. Jignesh Paswala sir, then Dr. Pk Pandey, Dr. Ramesh Mehta sir, our mind, then Dr. Santosh Agarwal, Dr. Renu Jaina, then Dr. Rishikesh. I thank to all doctors present here, those who have, they have given valuable time to attend this CME, resident doctors from Vision Medical, then our pediatricians from this area, then all ophthalmologists, those are present here, they have come from far away. And I would like to thank, not last, but Endor Pharma team. They have organized this wonderful event very nicely. I thank to them. I hereby declare this as a conclusion of this wonderful CME. Thank you, everyone, and please enjoy your dinner. Thank you so much.